So first of all, thanks so much, Somshila. She has done a brilliant job in putting this entire day together, and thanks for putting up with all my constant messages throughout the day. So today I've been asked to speak on HRCT and PET-CT in uveitis. And what I've decided to do is just show you some of the cases that I have treated so far and what I have learned from each of them. So when you analyze any standard textbook of uveitis, and especially as in India, it's infectious uveitis that comes first. And when you talk about tuberculosis, they write about the first thing that everybody talks about is chest X-ray, Mantoux test, acid fast staining, cultures, nucleic acid amplifications. Now, this culture of chest X-ray has unfortunately been deeply embedded in India, and I want to show you why it should not be so. So this is a very standard chest X-ray that we have all learned from our MBBS days. This is, of course, a CT scan. So, okay, let's see. This is a 27-year-old female who has come with acute pain, redness, reduced vision in the right eye since 7 days. You can see that there's a very classical string of pearls appearance in the inferior vitreous along with a significant vitreous haze. You see her chest X-ray, completely normal. And you can see the arrows of the HRCT, which shows extensive mediastinal tuberculosis, mediastinal lymphadenopathy in the lower two pictures. You can see the red arrows showing the spots where there is conglomerations of lymph nodes. Her Mantoux was very strongly positive. I gave her AKT steroids and she resolved fully. It's a 45-year-old male who has presented with non-resolving floaters in both eyes. Also a history of recurrent anterior uveitis. Vision is 6/6 bilaterally, mild groin granulomatous AU. See this again, vitreous haze, string of pearls appearance. You can see this little balls of vitritis, balls of infection within the lower vitreous. I did HRCT, Mantoux is strongly positive, TB quantiferon gold is strongly positive. See this. Large conglomerate lymph nodes within the mediastinum, as you can see from the red arrows. But note how clear the lung fields are. There is no consolidation, there is no collapse, there is no infection of any of the lung fields. All you can see here is mediastinal lymph nodes. So from this and from many others, I have realized that HRCT is the investigation of choice for chest imaging. Chest X-rays do not even image 50% of the chest. The mediastinum cannot be studied at all because it is directly behind the sternum, which is radio opaque. And in Indian patients, especially patients who present with ocular tuberculosis, mediastinal disease is extremely common. Almost all of them, with very few examples, have got lymph node tuberculosis, which is only in the mediastinum. Lung fields are always clear. Let's see another patient. Recurrent anterior uveitis in the right eye. Vision is counting fingers in one eye. You can see that there's a vitreous hemorrhage in the right eye and a very subtle retinal vasculitis in the left eye. I've done an HRCT. You can see a large conglomerate mediastinal lymph node. But note how clear the lung fields are. There is absolutely nothing in the lung fields. If you had simply done a chest X-ray, you would have been fortunate just to find query a hilar knuckle, but the lung fields would have been reported as normal and you would have thought this is normal. Let's move on to PET-CT. Everybody knows that HRCT is only part of the solution. I believe the final solution will come from a PET-CT scan. So what it does, this PET-CT machine actually combines PET, that is positron emission tomography, and CT, and fuses the two images to give you a remarkable clear and accurate image. So let's see some images. A 55-year-old female, previously investigated, treated for sarcoidosis. Vision is very good, 6/9 both eyes, but subtle bilateral granulomatous anterior uveitis. This is her HRCT. Post contrast, you can see large conglomerate mediastinal nodes, as you can see by the red arrows. Now, this is her PET scan. In a PET scan, the lighter the area, the orange, the more orange it is, that the higher is the uptake of 18 FTG. So it means higher the metabolically active the tissue is. That means it takes up more of the radioactive marker, which is 18 FTG. So you can see here that there is left hilar and subcondylar metabolically active adenopathy. It's reported in terms of metabolic activity. So the greater the metabolic activity, the more active is the tissue. You can see here on the lower right image that there is a aortocoval adenopathy also which has been reported. I'll show you another 55-year-old patient, pain, redness, defective vision. Vision is 6/6, 6/12, serpiginous like choroidopathy in both retinas. This is the fundus photograph. You can see discrete and yet some discrete lesions and some lesions which are starting to merge into the others. MAN2 is very high. Quantiferon gold is high, but HRCT is completely normal. You can see that there's a right paratracheal, precarinal, and bilateral lymph nodes. There is increased uptake, and there is also increased uptake in the left choroid. So this is one of the rare cases where I found where the HRCT was completely normal, but the PET-CT showed me findings. A 60-year-old man, discomfort, mild pain, vision is 6/6, mild non-granulomatous anterior uveitis. You can see that there are FTG avid mediastinal lymphadenopathy, pretracheal, precarinal, AP window, and subcarinal nodes. Notice at every patient how clear the lung fields are. And you can see exactly which nodes in the mediastinum are active and how active they are. This is a lady with panuveitis. You can just, I want you to see the uptake in the posterior half of both eyeballs. See the extensive mediastinal, pretracheal, and subcarinal nodes activity you can see here. Also, there is periportal adenopathy, bilateral external inguinal adenopathy here. So, in this lady had extensive disseminated tuberculosis with lymph node TB in multiple organ systems. And it is really important to know that one of the advantages of doing PET-CT, which I have found, is that you do. Can I just continue for a minute? Hello.
Sure, sir. You can wrap up in half a minute if possible. Yep. Thank you.
And so one of the advantages I found that when you have such disseminated disease, the more metabolically active the node that you detect on PET-CT, those are the best nodes to biopsy with the highest chances of having a positive yield. A last patient, she's come with a complicated cataract, very strongly positive MAN2. You can see cervical and mediastinal lymphadenopathy, supraclavicular, paratracheal, subcarinal. So what I really want to prove is why should we do a PET-CT? It helps you identify areas of metabolic activity. Mostly it turns out to be lymph node tuberculosis. It has the best potential to find sites of biopsy, and you can genuinely track improvement over a period of time.